Thank you very much for the excellent talk on that. I would like to welcome all the panelists and speakers, especially Elizabeth Berg from Sky, who has really worked hard and helped me a lot to really organize this session. And I would really like to thank from all Pakistan Society of Interventional Cardiology council members to Sky, as well as all the speakers who are able to spare some time and be here today to give very important talks on this session. Elizabeth, would you like to say a few words before I move on to the next talk?
Yes, I wasn't quite prepared. So I am home in Washington, D.C., and I am very excited to have Sky involved in Pakistan Live this year. Dr. Hanif, it's been a pleasure to work with you and your team. I think we have a fantastic session coming up, and I look forward to continual collaborations in 2023 into 2024. So I wish you all the best today, and I look forward to an exciting session. Thank you so much.
Thank you. Thank you very much. We really appreciate that. So we are going to move on to the next talk by Dr. Wasif Qureshi, who is a very well-known interventional cardiologist as well as structural interventionist from Delaware, who is going to talk about initiating a transcatheter valve program, key to success. I think this is very pertinent to us because a lot of centers in Pakistan are trying to start the interventional valve program, so this is going to help them to really see how they can do that. Thank you very much. Wasif, over to you.
Hello, good morning. Can everyone hear me clearly?
Yes, we can hear you.
Excellent. Good morning, everyone. Bashir, thank you so much for allowing me to present here at this great conference that you guys are running. I just had a chance to look here into the room A, and now, great program going on over there. So you gave me this talk to present about what are the keys to success. And I'm just going to go through what my thoughts are, and I'm going to end with some conclusions as well. So I'm going to talk about the TAVR program, the TAVI program, the TEER programs, and the left atrial appendage closure program. We'll not be talking about tricuspid pulmonic valves right now, and then we'll talk about the conclusions. So essentially, there is a national coverage decision in the US about TAVR. So we need to look at what do the hospitals have and what are requirements. So credentialing requirements for hospitals without TAVR experience, they should have 50 open heart surgeries in the previous year before initiating the program, of which 20 should be aortic valve related procedures in the last 2 years prior, and should be doing about 300 PCIs. The heart teams must have the following professional experience. They should be interventional cardiologists who've had 100 career structural heart procedures or 30 left-sided structural heart procedures. And of course, device training specifically for the devices that are going to use needs to be done by the manufacturer, which are FDA approved. Part of the team, of course, are the cardiothoracic surgeons. They should have 100 career open heart surgeries, of which 25 are aortic valve related surgeries. This is for places who've had TAVR experience. Hospitals maintain the following annual volumes: 50 AVRs, TAVR or SAVR per year, including 20 TAVRs in the prior year and 300 PCI. So 20 TAVRs does not sound much, but it's now become the baseline to which people should do the minimum amount to maintain their privileging. Again, patient care has to be done under a heart team approach. The heart team includes interventional cardiologists, cardiothoracic surgeons, and I'll talk a little bit more about this as we go along. Previously, we used to have 2 surgeons sign off, but no longer required, and only 1 cardiac surgeon and 1 interventional cardiologist who needs to sign off to see whether this patient needs which procedure, either TAVR versus SAVR or medical therapy or just palliative therapy. So, like I said, it's a collaborative team approach. Patients with severe aortic stenosis referred by the referring physician. They're referred to a valve clinic. In the valve clinic, patients undergo additional testing, which includes functional assessment, STS score, clinical evaluation. You do a CT scan, right and left heart cath if required, and then the treatment plan is discussed with the surgeon as well as with the IC, and then you can have a multidisciplinary team approach in which you have echocardiographers and other members of the team as well. Some places have TAVR clinics, most places do. You have the surgeon and the IC independently seeing patients, and then they discuss with the patient as well as with the other team members. We in Delaware have a hybrid approach. We have some who are hospital-employed cardiologists who are part of the valve clinic, and some of us are private cardiologists who see patients and will refer patients to the surgeons independently. So we have a hybrid approach in how we manage our patients, and both work equally well. So the goal of the TAVR clinic is, again, getting all the information, treatment options, patient family make choices, and then there's ultimate collaborative approach to this. And these are all requirements if you want to have a good structural heart or valve program. Of course, to coordinate all this, as physicians, we need someone to coordinate us because we can get lost, we can go on tangents. So we need a TAVR coordinator whose job is to coordinate all the tests that we're ordering, making sure if patients are coming from outside facilities, all the records have been sent to us, the facility communication, expedite the process of logistics, make sure the time in the cath lab or the OR is available for these procedures to be done. And this is just a slide which shows you all the work a TAVR coordinator puts in. So don't minimize this at all, because this is extremely, extremely important. If you don't have a good TAVR coordinator, then your program is going to sink. As you can see, they do a lot of work behind the scenes to make our programs successful. And then, other than just having the surgeons and the operators, the ICs, you have to also make sure that you have cath lab individuals who are trained on devices. Make sure if you have imagers, make sure if you have cardiac anesthesiologists, they know what's going on. I remember in 2011, when TAVR was approved in the US and we went to training for Columbia, we had to take the cardiac anesthesiologist as part of our program for the training as well. So that no longer may be required, but you have to make sure that your cardiac anesthesiologist also knows what's going on with the case. Of course, ValvePoint is something that is an online application which Edwards has, in which you download all the images and they return them back to you. And then device preparation, either done by someone in your facility or sometimes the company can provide that as well. And there should always be a procedure dry run to make sure everything falls in place. The most important things that we see where teams don't know what's going on is when we are doing alternative access like carotid or subclavian sometimes, is where the anesthesiologist is going to be positioned, where the operator is going to be positioned, and how the access is going to be done. So again, there are multiple diagrams that are available, which can be shared with anyone who wants to be doing this, to show where each operator is positioned and where the anesthesiologist is going to be positioned for these alternative access to make sure that you have success in doing these cases. And again, a minimum of 2 TAVR proctored cases when this happens, and sign-offs are required after that. Coming to transcatheter edge-to-edge repair, again, just like TAVR, each patient's suitability for surgical mitral repair, TEER or palliative therapy must be evaluated and documented and made available to other heart team members. Now we are doing functional as well as degenerative MR for patients with mitral clip. For the Pascal device, it's only degenerative MR at this point in time. And therefore, again, getting all the information in to the teams, patients being evaluated, echoes, 3D echoes being performed, and to see what is the best method to proceed and which kind of clip to deploy in these patients and how many to deploy. Again, this is more of an imaging procedure, so you have to make sure that your echocardiographers are really on board and can perform these procedures adequately and adeptly as well. Again, this again talks about the TE, and it talks about that the person doing the TE should not be the one giving the anesthesia, but there are places where this happens with nurse anesthetists, just with the anesthesia and the anesthesiologist being the TE provider as well. These are volumes, and I will be talking about volumes in a presentation further down in this session as well. Again, you should be the heart team hospital participating in the prospective national audit registry that comprehensive enrolls to your patients. accepts all manufactured devices. You got to follow the patients for a year, and you have to be compliant with all the regulations that FDA has in place. Talking about left atrial appendage closure, this is for non-valvular AFib, and the LLA closure devices are covered when the devices receive FDA approval. And right now, there are two devices that we're using, the Watchman and the Amulet, which have FDA approval, and other devices are currently in trial stages as well. Again, CHADS-VAS score of 2, or CHADS-VAS score greater than 3, CHADS score of 2, formal decision-making between the cardiologist, the interventional cardiologist, and the referring physician to make sure that the patient actually needs the device based on they cannot be candidates for long-term anticoagulation due to bleeding, falls, high-risk occupations, etc. And again, the providers should receive training prescribed by the manufacturer, have performed more than greater than 25 interventional cardiac procedures that involve transseptal puncture and intact septum, and then continue to perform greater than 25 interventional cardiac procedures that involve transseptal puncture through an intact septum, of which at least 12 are left atrial appendage closure over a 2-year period. So this is important to keep your skills going on for year to year.
Wasif, you have 1 minute
In
left.
conclusions, you have to have interventional cardiologists, cardiovascular surgeons, cardiac anesthesia, physicians dedicated to structural heart procedures. You should have good interventional cardiographers with 3D imaging capabilities or 4D, hospital commitment for developing and expanding programs, good structural heart coordinator 1 or 2, good radiologists who are reading these CT scans or MRs appropriately, trained cath lab staff or CVOR staff for structural heart procedures, good imaging equipment, continuing education for new generation devices, new procedures, be involved in research. Also have to have heart failure cardiologists for functional mitral regurgitation to evaluate patients. Should have structural heart weekly meetings, M&M meetings after procedures, CME to assure good clinical outcomes and participate in national registries. And this is our, as you can see, the structural heart team is not a small team. It's a big team. This is our team at our institution. And there's some of us who perform all procedures and some of them who do only certain procedures. And thank you very much.
Thank you. Thank you so much, Wasif. An excellent overview. I think it will be very helpful for us, those of us who are trying to start these programs in different institutions. So we'll have the question answer after the next talk.